Okay, we're going to go ahead and get started. So welcome everyone to March for Science New York City's Health Policy Panel. It's the second panel in our Summer of Science Policy. My name is Ingrid Paredes. I'm the co-chair of March for Science New York City. For those of you who are new to the Science Justice family, we are a volunteer organization that began in 2017 with the National March for Science movement. And essentially what we are is a nonpartisan platform committed to three things: the open access of scientific information, the use of science for the public good, and in the protection of human and environmental rights. And essentially in 2020, what that means, as all of you know, we have the big election coming up. And our goal for this summer is to put data, scientific information accessibly into your hands so that when you go home to the polls, when you talk to your friends about your hot takes on policy, you can bring all that knowledge that you learned here tonight, do your own research further too, and bring it back to them. So every week, starting last week, as I'd mentioned, we've been having these policy panels today on healthcare, coming up next, which I'll talk about later in the evening once this panel wraps up, on issues like immigration, climate change, education, all with the same goal of bringing science to your homes and then to the ballot box this fall. So without further ado, since we have just the hour to get through this really exciting conversation, I'm going to pass it off now to our amazing panelists and moderator. So Micah, I'll pass it off to you.
Hi everyone, welcome. I guess we can go around and we'll just introduce the panelists and we can all speak to ourselves, just provide a brief bio to update everyone. And then I will return and just give us an overlay, but we'll get started and then hand it off to Steffie. And so, hi everyone, my name is Micah Savin. I use they, their, them pronouns. I'm an alumni director of diversity inclusion here for March for Science. I'm also a neuropsychological extern at Mount Sinai here in New York City. And then I am a co-founder of Wisdom Wings, which is an international work group that addresses health inequities in brain among Indigenous populations throughout the world. And so that's me. Steffi, do you want to go next?
Yeah, I'm Steffie Woolhandler, and I've been a professor of medicine at Harvard Medical School. I'm currently a distinguished professor of public health at the City University of New York at Hunter College, and I do see patients occasionally at a clinic in the South Bronx in New York City.
And Dior?
Hi everyone, my name is Dior Vargas. My pronouns are she, her, and I am a queer Latina feminist mental health activist. I work on the intersection between race, ethnicity, and mental health, just talking about access to care for Black, Indigenous, POC, as well as the quality of their treatment, among other things. So just using art as a form of activism.
And so just to give you guys an overlay today, obviously we have like amazing panelists, so I'm really excited, like very diverse backgrounds. But so today we're gonna kind of start, I'm gonna give you just a brief overview, a very macro approach to, hey, how did we land with the infrastructure that we have today in America, right? So I'm gonna discuss in terms of, take a historical perspective on how we arrived to have the infrastructure that we have in the United States that propagates inequity in health. And I'll take an Indigenous lens on that, because that's my background, that's also my area of expertise. Then we'll pass it on to Steffi, who will describe kind of the history and the current state of policy going on here. She'll give you a very nice facts, hard data coming at you. It'll be a great point of discussion. From there, we'll kind of turn and we'll be, okay, so where are we at right now? What gaps are there? You know, where do we really need to address inequity most? And that'll largely be a discussion that'll be led by me and Dior. Of course, Steffi will come in and provide her expertise as well in those moments. We'll kind of then end together. We'll just provide some like future work that needs to be done, both in terms of research, policy, practice for the everyday individual. So let's kind of just get started. So basically, so in terms of the infrastructure where we're from today, I think most of you are well aware of the Great Genocide. The Great Genocide happened when Europeans came over to America, right? At that time in which we, okay. Sorry. So Steffi, would you mind just pulling down for a little bit for your
Yeah, I'm sorry. I thought you were telling me to get going.
Yeah,
Let me get,
okay.
There we go. Yeah.
So basically, in terms of, we have the Great Genocide, and the Great Genocide was modeled and utilized by Hitler. He really admired the Americans for coming over and kind of eradicating as much as they could possibly do the Native Americans here in this country. And so at that time, what happened thereafter, right? So there's just this great war, this very targeted annihilation of a racial population. From there, what happened is that these groups, these tribal members were disbanded, right? They were moved into concentration camps, you know, very much reflecting and analogous of what Hitler then did in the World War. From there, these individuals were kind of reclassified, moved around the country. So they were taken from their area of origin, right, where they had specific diets, specific activities, you know, medical practices in which they utilized, and of course their own cultural identity. And they were relabeled by Americans, right, who are colonizers. From there, we see that, you know, Native Americans were placed into schools. And these schools, what they did was they attempted to force assimilate Native American populations. So what happened in these classrooms, you know, you were a student there, you sat down, you were given a new name, an English name, right? You were not allowed to speak any type of indigenous language or so forth. And you were brought into kind of what we now have as white academia. But unfortunately, what we saw in this time as well is that individuals, if you did speak your language or you did use your native name, you were murdered in the classroom in front of your peers, right? From there, we move on, you know, come into the 80s and so forth. You know, the American government was like, hey, you know, at this time, we don't really see you as like fruitful, you know, individuals. What we want to do is we want to assimilate you. So right now we have you isolated on these reservations, right? We've moved you from your rich land, right, and taking you to these places that don't have a lot of resources. There's not really great availability in terms of healthcare or anything like that. Now what we're going to do is we're going to split up your families, and we're going to send 50% of you guys off to big cities in the United States, and you can assimilate and you can become fruitful members of America. And so then from there, Native Americans were then spread out, kind of reforced, and now we have this like large urban Native American population, right? It's kind of 50-50, it's split. Some individuals are still reservation-based, right? And some are very urbanized. And kind of what this story depicts to you is, you know, the settlement of America is really, really entrenched within inequity, right? And racial injustice. And, you know, oftentimes I think we go to speak to, and there's been a strong kind of dialogue that's been going on that we really need to acknowledge with Black Lives Matter, right? And so, you know, this is true across populations. And we really need to take a historically informed approach to the work that we do and the discussions that we have. And so that's why we wanted to start today with this. And so that kind of that puts us kind of, okay, what is the state of policy today? And that's gonna take us off to Steffi. So Steffi, if you're ready, go on.
Okay, now it's my turn. Sorry about that. Okay, I don't have any financial conflict of interest. I have co-authored some papers with Senator Elizabeth Warren and served as an unpaid policy advisor for Senator Bernie Sanders, but wasn't paid for any of that. The United States is quite exceptional in terms of our health. When we compare ourselves to other developed nations, as I do on this graph, other countries have continued to improve their life expectancy, and the United States was improving their life expectancy really in the middle of the pack until about 1980. But since then, these other nations have continued to live longer and longer, while life expectancy in the United States has lagged. And in 3 of the last 4 years before COVID, life expectancy was actually declining, and almost certainly it's going to be declining this year as well. And that is really unique in the developed world. Everybody else keeps living longer and longer. This is due primarily to what's going on with people in the bottom half of the income distribution. What I'm showing in this slide is life expectancy at age 60 by people in the top half of the income distribution, which are the blue line on the top. And you'll see their life expectancy after 60 has been going up and up and up. whereas the life expectancy of people in the bottom half of the income distribution has actually been quite stagnant. So that in the 1970s, there was approximately 1 year difference in life expectancy between the richer half and the poorer half of Americans. Now there is a 6-year difference in life expectancy between people in the top and bottom half of the income distribution. We also are unique in the developed world in having so many uninsured people. We had about 30 million uninsured people before the COVID epidemic. In the last 3 months, we believe that probably somewhere between 7 million and 13 million Americans have lost their health coverage because they or a loved one lost their job. Being insured does, in fact, increase your risk of dying. This is just a study we did looking at the data really mathematically about what studies in the past have found in terms of the relationship to being uninsured and dying. And the summary is just in the headline that yes, indeed, being uninsured will raise your risk of dying. Not terribly surprising, but believe it or not, this was kind of news when it came out 3 years ago. But in addition to being underinsured, many Americans face the problem of being underinsured. That is, they have health insurance, but they still can't afford medical care because of gaps in their coverage like co-payments, deductibles, and uncovered services. And according to the Commonwealth Fund that studies this every 2 years, the share of Americans who are underinsured with only partial coverage has been going up, up, up over the past decades. And when people have only partial coverage, for instance, if you have a high deductible plan, that can cause dangerous delays in care. There's a lot of data on this, but I'm just going to show you this one. This is about how long ladies with breast cancer, or people with breast cancer, if you will, how long they delay getting the care they need if they have a high deductible plan versus a low deductible plan. And the different colors are just people with different levels of the income scale. But it turns out if you have a high deductible plan relative to someone with a low deductible plan, you delay getting biopsied by about 2 months, you delay your diagnosis by about 6 months, and you delay the start of chemotherapy by an average of about 6 months. So it's actually quite harmful for people when they get sick to have to pull money out of their pocket to pay the deductible. It delays the care they need, often in life-threatening circumstances. The United States is also in the rapid rise of healthcare costs. Here I'm comparing to Canada, and most of the rest of my comparisons will be to Canada, which has a Medicare for All program since about 1970. And if you look at healthcare costs as a share of GDP, the US on top, Canada on the bottom, you'll see that the two nations had essentially identical healthcare costs until Canada's implementation of Medicare for All. And since that time, Canadian costs have still gone up a little bit, but the US costs have soared and soared and soared, well above Canada's and indeed well above any other nation on earth. This has driven a tremendous growth in the number of administrators in the business side of medicine, the people who are taking care of getting paid, of the money, of billing, so that healthcare managers have been growing many-fold faster than the growth in physicians over the past decades. This can be summarized in a way by a book by my former colleague, Regina Hertzlinger, where she said, we need market-driven healthcare. We need the market to decide who gets healthcare, and we need to transform healthcare into an industry that sells commodities rather than a public service. And the book was somewhat controversial, but in fact, its message has pretty much been taken to heart. And we now have been going every year toward a more market-oriented, a more profit-oriented healthcare system and away from a model of public health and public good. We've seen this tremendous growth in the overhead of our insurance companies. Overhead is a share of the premium you pay that never comes back to you as medical care. And on a per capita basis in the United States, we're spending almost $842 per capita for health insurance administration, which is many-fold higher than what's going on in countries with Medicare for All or some form of national health insurance. The United States model, in a way, for some sort of public insurance would be the Medicare program. And Medicare was started in 1965, 66. And this is slightly a joke. They enrolled 19 million seniors into the Medicare program and started paying their bills in less than a year. And this was literally the software they used, a postcard that you checked off a couple of boxes and signed your name, and that enrolled you in the Medicare program. It was a simple system because it was based on Social Security. They had your name, they had your address, they knew whether you were alive or dead, right? And you just checked the box, and then it was social insurance. It was paid for by taxes, and that is why the original Medicare program was so simple. It's not just the issue of the administrative complexity associated with profit making. At the insurance end, there's a tremendous amount of complexity involved in running a business from the hospital end. And this is something we've published several times, studies on this, comparing hospital billing and administration in the US and other countries. And again, on a per capita basis, every person on this call, there's been more than $1,000 spent in some sort of hospital office that has nothing to do with medical care, that just has to do with running the hospitals as a business. Cleveland Clinic was being told by the Trump administration they had to post all their prices, okay? And they said, oh no, we can't possibly post our prices. And Cleveland Clinic is a giant medical center in Cleveland, okay? We have many different payers and multiple different products with each payer. We have 3,000 rate schedules. We have 70,000 charge master lines, prices, if you will. So the number of data points needed to post all of our prices online is 210 million. This was just, they didn't want to post them, right? But this is a tremendous waste of everybody's time and money, setting a price on everything in a hospital. Healthcare shouldn't even have a price. You should go and get what you need, just like you would go to a public school and get what you need. And there's not a price on a teacher grading homework, okay? There's not a price on the chair, you know, your right to sit in a chair in a classroom. Hospitals shouldn't be having prices either. In physicians' offices, and I used to run my own faculty practice, we in doctors' offices spend about $500 per capita just keeping track of the bills for patients. So the cost of running healthcare as a business relative to the situation in Canada, where they're spending a fraction of that on their billing related expenses because it's Medicare for all. And again, a hospital data from Duke's Medical Systems, they say, medical center, they say they spend $100,000 each year for every primary care physician in their system just sending the bills. Now, people are familiar with their Medicare for All bills. This is actually Senator Sanders introducing the bill into the Senate last year. In addition to Senator Sanders' bill that got 17 Senate co-sponsors, there's a large bill in the House of Representatives sponsored by Pramila Jayapal that has over half of the Democratic caucus in the House signed on as co-sponsors. So this is not pie in the sky. These are like real bills that have been written or that are sitting there in Congress and will probably be reintroduced next session. So we have some sort of model about what we do. Now, the question is, do we need to go to Medicare for All, like Sanders and Warren were advocating and Pramila Jayapal's advocating, or is it going to be enough to just do Medicare for More, some sort of buy-in option, right? Public option. Do we need Medicare for All or Medicare for More? And I'm going to spend a few minutes taking you through this because we're going to hear an awful lot from Biden, and I do hope he gets elected, but all right. We're going to hear an awful lot from him saying, well, Medicare for More is the best we can do. We can't do anything better. And of course, this is Biden, and he is supporting a public option. And he's also going to lower the Medicare eligibility age to 60, which, by the way, that's a very good idea. We ought to lower it all the way down to 0, in my opinion, but lowering it's a good idea. The problem with a public plan called a public option competing with private profit-driven insurers is illustrated in the so-called Medicare Advantage program. And I know nobody on the call knows what Medicare Advantage is unless you have your grandma sign up this year, okay? But under the Medicare Advantage program, they have transformed the Medicare, the traditional Medicare public social insurance plan and said, well, if you're a senior, you can get the taxpayers to pay your premium to get insurance from a private insurer. We call that Medicare Advantage. Okay, and about 1/3 of all Medicare seniors are now in Medicare Advantage plans, but they are really private plans. They say Medicare Advantage, but they're really private insurance plans. Traditional Medicare has overhead of about 2%, but the private plans have overhead of about 14%. And you might say, well, gee, must be that traditional Medicare can outcompete the private plans. Look how low their overhead. But exactly the opposite is the case. The private insurance plans have grown year upon year and have outcompeted the more efficient public traditional Medicare. Now, how do they do that? Well, they've got two strategies. They use cherry picking, so they selectively enroll healthier than average seniors, and they do something called lemon dropping. If you are enrolled, they find out your costs are too high, they make it inconvenient and difficult for you and expensive for you in ways that encourage you to drop out. And this can be implemented through marketing strategies, like putting your sign-up offices on the second story of a building that doesn't have an elevator. It can be done through network manipulation, like having lots of sports medicine clinics for people who are still physically active, but when it comes to things like wound care or nursing home care, making it very hard for people to get it. They do that for benefit design. They do that by the hassle factor. If you need care that's expensive, they can just hassle you, and so you leave and go back to the public plan. So the same dynamic's going to come down if you have a public option trying to compete with private plans. They're going to cherry pick, they're going to lemon drop, and essentially turn your public plan into kind of a high-risk pool that takes care of all the sickest patients, and the more profitable patients are going to end up there with the private plans. And this is just an illustration this last year about enrolling people matched by diagnosis. So asthmatic versus asthmatic, the private plans have gone and cherry picked and gotten the healthiest asthmatics. So even giving a risk score and matching people by diagnosis, we still see extensive cherry picking by the private plans that, basically pubs will drive the competing public option plan out of business. It's illustrating this older study, but the same dynamic is going on. A little bit complicated, but let me explain. What I've done is graphed the costs, the costs for someone in the traditional Medicare program in yellow, arbitrarily as 100 in yellow. Now, the people who were subsequently recruited into the private plans had lower costs the year before, only 66% as high as the average Medicare beneficiary. So that's that cherry picking. And then after these people leave the private plan, return to traditional Medicare, their spending in the next few months is almost twice the Medicare average. They have been lemon dropped because they need high cost care. So it's the Medicare revolving door, the private plan revolving door, the healthy go in, the sick go out, back to the public plan. And the third strategy, and I'm sort of on a fruit thing here, I guess, but is really outright cheating, which has been ubiquitous within these private plans that are supposed to compete with Medicare. They consistently overcharge the taxpayers by claiming the patient has all sorts of diagnoses that auditors can find nowhere on the patient charts. $10 billion a year in billings for these imaginary diagnoses, if you will. And, basically the federal government just lets them get away with it. $10 billion in overcharges. At most, the federal government recovers a few million from them. So cherry picking, lemon dropping, and cheating, the private plans will not allow themselves to face a level playing field with the public option. And that way, allowing public and private plans to compete really undermines the ability to achieve Medicare for all and universal coverage. So, what I think about the public option, I think we've got privatized health care on one hand, that's building the house out of straw. We've got single payer, which would be building our healthcare system out of bricks. And then there's a public option, people in the middle who say, let's compromise, we'll build it out of twigs with the public option. Okay, so just to review why I think the public option will fail, I think there's going to be less savings on insurers' overhead because there's still going to be private insurance out there. You didn't get Medicare for all, you left private insurance in place. There's going to be zero savings on the doctor's administration, the hospital administration related to billing, which I talked about. The private insurers are going to build the fields under the Medicare Advantage program, raising system-wide costs and perpetuating all sorts of bad things like narrow networks and cherry picking and lemon dropping and cheating. And you don't have a functional system. You have a very expensive system that doesn't function very well. You're going to have higher system-wide costs than single payer that are going to assure political pressure to cut benefits and reimbursements in the long run. So you'll end up with a skimpier benefit package, and you're going to fail to eliminate the structural racism of unequal financial access to care. Haven't spent much time on that, but a lot of the failure of minority folks, of people of color to get adequate access to medical care is because this profound inequality in the payment with white Americans primarily covered by private insurance, not completely, but primarily covered by private insurance or Medicare, and lower income people either uninsured or covered by Medicaid. It offers unequal financial access to care that drives unequal delivery of care. Finally, just to summarize it, again, looking at what happens when you have public and private plans competing is in the Medicare Advantage program. A very good study came out just this year in the American Economics Journal, okay? It turns out that these private plans are actually raising the price to taxpayers. They're out-competing traditional Medicare, but raising the price, this is a per member per month price, raising the price to the taxpayers through their cherry picking, lemon dropping, and cheating. For any level of spending, single payer would purchase more care and less administration than the current financing system, and also then public option, which would be an improvement, but not enough of an improvement. Now, we've been hearing that voters want their private insurance, that they would never go for Medicare for all. But it does depend on how you ask the question. And this is actually the last slide I'm going to show. But if you go to the voters and say, do you want Medicare for all? And you don't describe it further, it turns out, a majority support it, 53%, right? They support it just with no further description. You go, do you want Medicare for all if it means you have no choice of insurance? Well, support drops off. It drops down to 46% support Medicare for all. But if you say, okay, do you want Medicare for all if you get your choice of doctor and hospital, but you have no choice of insurance? Look what happens to the support for Medicare for all. It goes up even higher than it was in the first place. So the choice people care about is choosing their doctor and hospitals and treatment. They confuse that sometimes when they're asking a poll with choice of insurers, but they don't really care. Nobody cares that much who pays the bill as long as somebody else is paying it. Okay, well, that's it. I'm looking forward to hearing what the others have to say here.
Thank you so much. That was really, really, really insightful. I think it was one of the things that you touched upon basically was, we all want accessibility and availability. And earlier when I was speaking of, hey, let me contextualize the world in which the America that we know it, how has it been built, right? And it's been built by, opportunizing racism and building an infrastructure in which some people don't have access and some people don't have availability, right? And those individuals are individuals who typically come from lower socioeconomic status backgrounds, right? And what we utilize capitalism in a way in which we can further stretch that disparity, right? And cause greater and greater and greater poor access and poor availability in healthcare. Do you kind of agree with that? Do you have something you want to add to that?
Okay, I mean, I agree with it entirely. And, by far the worst access problems are for poor and minority people. But the insurance industry and the drug industry have also exploited racism to set up a really bad system. And it's bad for everyone, unless you're a millionaire. It's actually a very, very bad system. And, hundreds of thousands of Americans every year are driven into bankruptcy by our terrible healthcare system. And the majority of them are actually middle class, right? it's a very bad system for everyone but the billionaires and the millionaires. It's better for white people, it's better for affluent people, but racism has allowed politicians and powerful corporate actors to establish a very bad system that's profitable for corporations and very expensive and lower quality than it should be for everyone.
Mm-hmm. Definitely, definitely. Thank you so much. So in terms of that, I think one of the things we wanted to move on was describe, hey, today, what are some of the solutions that Medicare for All would provide for us, right? And what are some of the greatest inequities? And Dior, I was kind of wondering if you would be able to kind of contextualize that, given COVID right now and the racial disparities that we're seeing there. I did want to note too, when I see racial, I mean ethnocultural, right? I think we use that word. It's probably a more PC word, but that's what we mean by that. Dior, you're free to go whenever you're ready.
Sure. Yeah, thank you so much for having me, first off. So, yeah, I mean, clearly with COVID, we realized it really shows so many inequities, not even health related, but even when it comes to access to internet and Wi-Fi, access to having those electronic devices. So it just really brings to light a lot of the disparities. So specifically when it comes into healthcare, a vast majority of Black, Indigenous, POC are experiencing COVID as well as dying from COVID. I mean, I can speak for myself, my entire family, including me, all got COVID. Some were hospitalized, all of us survived, thank God. But that just really shows the lack of support. And we really need to think about the cause of the cause, because social determinants of health impact how our health outcomes. So at least for Medicare for All, I think that would help with lowering costs, specifically when it comes to those who are unemployed. Because of COVID, there's a huge amount of people who are employed, so the employment rate has gone up. And that would really help those people get access to care, because right now it comes across as though you need to have a job in order to have health care. And so it's kind of viewing it as a commodity and a privilege rather than a right. So for sure. And then also even thinking about the ACA and how people of color are less likely to have health insurance, specifically when it comes to those states, the 14 states that have not signed up for Medicaid. And so that's another problem that really prevents people from getting that care. And it's mostly in the South, and the majority of people who live in the South are Black, Indigenous, POC, but more so Black folks. So yeah, I would say that's really what's going on. I mean, especially with unemployment. A lot of times when people become unemployed, they have the option to sign for COBRA, which is inaccessible, too expensive, and people just feel like they cannot get that care. So I think Medicare for All would be extremely important and provide people with the support that they need.
So I think what I would like to do for our viewers is, because what you said is so rich in information, but I think I want us to break it down a little bit so that, these individuals can walk away being able to relay this. And I think we can do so in a mechanistic fashion. And so you spoke of social determinants of health. And so, I think people aren't fully aware of what those are. And so earlier when I was discussing, hey, historically, this has been the education inequities that we see among Native Americans. These have been the geographical factors, the diet factors, the healthcare factors that have been kind of through policy and through racial implementation by the federal government, inequities have occurred, right? And those are factors that impact health, right? So we know how educated you are informs what healthy behaviors you have. If you smoke, if you don't smoke, can you take action? Can you exercise and so forth? And so that then obviously results in better health among certain populations. Some populations have great educational systems. Others do not, right? And that is through gerrymandering and redlining, and we've seen that throughout history again and again and again. And so I kind of wonder too at that is, how can we approach these health inequities every day, knowing that for the past 500 years or so forth, there have been individuals who have not been given equal opportunity? I just think it's a big question to ask. And do you think Medicare for All will be able to kind of, at least in these situations like COVID and so forth, be able to address that?
Yeah, I mean, when it comes to social determinants of health, universal healthcare only really provides help to access, but there's stigma, there's a lack of understanding. So it really prevents people from even getting that access. I mean, there's so many things that come into play. So it's not going to be the only thing that's going to solve people when it comes to social determinants of health. You know, their environment, the economic status of those individuals, the lack of healthy food, like food deserts, like they are in situations that prevent them from being able to have a healthy lifestyle. So a lot of times the onus is on the individual, and really it's a community issue and something that we all should really focus on. So yeah, those are just some of my thoughts surrounding that topic.
That's great. I think it's really interesting, and I think it's that this is probably, Medicare for All is probably the important first step for us to be taking,
Yes.
in being able to address these inequities, right?
Yeah.
Steffie, do you have anything to comment on that?
Yeah, okay. What Medicare for All does is it gives equal financial access to medical care. That would go a really long way toward getting people the medical care they need. I agree with Dior completely that we're going to have to do other things to make the society more equal. We need more than equal medical care. We need equal schools. We need everyone to have safe housing and clean air to breathe, and a living wage, and social supports when something goes wrong and they can't earn that in living wage, and a good education. We need all of those things too. I work in healthcare, so I think about it a lot. And, we need to equalize things in healthcare so people have equal access. But in addition to that, I've thought a lot about the idea of reparations. And, reparations are not just about money, right? There's a whole lot of things that we really have to repair in medicine. And we, in medicine, need to take on the obligation to repair the damage that has been done to the health of poor and minority communities by racism and ethnic discrimination and gender discrimination. So we need to be thinking about those things as well. But the first step, and thing I've really worked on all my life, is let's get equal financial access to the healthcare system. So when Bill Gates shows up at Columbia Presbyterian and a homeless guy shows up at a Columbia Presbyterian, they bring the exact same financial remuneration to that hospital, which should be none, right? They're going to get a global budget under single payer. They're going to get their budget picked up. But there's not going to be any decision, do we want to care for Bill Gates versus a homeless guy based on who brings in the most money? And that's, to me, just a first step, and the stuff Dior is talking about is really important too, and those are other steps we need to be taking.
So I think one of our lessons here today is that America was not built equally for everyone. One of the questions that we have here is about the Affordable Care Act and kind of current attacks on it. And one of the things that we really do need to recognize, and as a society we don't take into account enough, is really that, especially for individuals who are differently abled, accessibility is a huge issue in America, in which we do not, is not the first thing on our mind, even though there's a large amount of or a bare minimum of legal laws that need to be followed in creating structures and so forth, but they do not in any way, are they pliable, or do they work around that? And so that's something that we need to take into account of. When we speak to minority populations, quote unquote, I think one of the other things to consider is that by 2050, America will be a minority majority country. And so we are very, very, very far behind in being able to really serve our overall the population, right? To be able to serve Americans. To be able to serve Americans, we need to be serving diverse communities now, so that in the future we're prepared. And that includes individuals of diverse sexual, gender, ethno-racial, differently abled, and so forth. Dior, is there anything that you want to speak to specifically on the Affordable Care Act?
So, I mean, it's something that we probably were going to talk about deeper into the conversation, but when it comes to the Mental Health Parity Act, initially when it first came out, it did not force plans to include mental health care as part of that. And the second version of the Mental Health Parity Act included mental health and substance use disorder. And so when it came to the ADA, they required that every plan covers those services. So the ADA does provide a lot of support and makes additions to acts that are supposed to be helpful for people, but it did what it had to do. So, and even when it comes to when you were talking about disabilities, it definitely is the last thing we think about. We also don't think about mental health conditions as a form of disability. And there's so many things that people don't know about it, and specifically when it comes to the ADA. There needs to be more work in terms of ensuring housing for individuals. There are a lot of people with disabilities who do not have jobs. When it comes to voting, Biden has included a disability plan where that would focus on providing support to individuals, providing support when it comes to getting jobs. So there are a lot of things that the ADA has done, but still needs working on. But yeah, I apologize. I went from the ACA to the ADA.
Oh, that's fine. Yeah,
Two important things. Yeah.
Yeah, two very important things. I think one of the things that I have wanted to comment on too, and I think it's something that Americans aren't very aware of, is that, you know, we do not take a strong approach to preventive medicine here in America at all. We know that there are modifiable factors throughout the lifespan that will strongly predict what your health outcome will be in terms of your morbidities, your mortality, and so forth. And we do not really take them into consideration. You cannot get coverage so that you can prevent yourself from getting health disorders later in life. And it is really sad and unfortunate. And scientists again and again and again and again have come up with strong data suggesting that these are the factors that we need to be modifying and move forward. And the insurance companies are not responding appropriately. And this is really strong in terms of when we speak of the duality of the physical health versus the mental health. Me as a clinical neuropsychologist, this is my field. My field's been around for quite some time. We know that what the heart does, the brain does, right? And what the brain does, vice versa, so does the heart, right? It is one system that is synergistic. And for mental health to be ignored it's uncanny, it's unfathomable for me. Sorry, I'm worked up. But Dior, so if you wanted to speak to that a little bit more, I think that would be excellent. Great.
Yeah, no, I'm just glad that they have included substance use disorders because it's part of behavioral health and it's something that people need support on. And when it comes to the preventative aspect, you know, there are studies that show that people who have primary care physicians, those who have built trust and relationships with those individuals, have better health outcomes. So yeah, we really need to focus on prevention and not trying to catch up and solve problems that could have been resolved to begin with.
Do you or Steffi have any comments about, you know, inpatient and outpatient? So what we have is, you know, we have these extreme rates of prices that are going on when you're an inpatient, so only very few people can afford them, and they're in extreme cases. I'm thinking specifically within psychiatry, you know, inpatient cases, individuals who are living their large majority of their life in and out of inpatient care. And then they're going to outpatient care, but it's not a smooth transition in terms of symptomology and severity of disorders. It's really not appropriate for a lot of individuals. There's not a plan in which it appropriately transitions individual and provides that tapering effect that we would see that would predict kind of positive outcomes in terms of remission and things like that, especially with mental health and addiction and substance use. And so I was wondering if either of you guys wanted to speak to that a little bit more, because that's an issue within the American healthcare system as well.
Okay. Well, I want to tell you that the private insurance industry hates mentally ill enrollees. They hate them because their care is expensive and it loses them money. And the insurance companies, let's be clear what they are. They are for-profit corporations, okay? Many of them are traded on the stock market, but you know, generally they're for-profit corporations, majority of them. And the executive, like the CEO of an insurance company, has what the lawyers call a fiduciary obligation to make as much money for shareholders as possible. Okay, so the fiduciary obligation is not to the patients who may need care. The fiduciary obligation is to make as much money for the shareholders as possible. And if the shareholders find out that the CEO is not doing that, they'll fire him or her and put someone else in there who are going to put the shareholders first. And because mentally ill people, I mean, many mentally ill people do very, very well, you know, and they get some therapy for a while or some medications for a while or some social interventions for a while, and they do just fine. And I'm really happy about that. But there are a lot of mentally ill people who do, as Micah was saying, incur a lot of medical care and a lot of costs, and the insurance companies hate them and try to get rid of them. So people who develop a mental illness while they're getting private insurance are often pushed out of their private insurance, sometimes because they've been pushed out of their job, but often because the insurance company really doesn't like them and doesn't want to make their care convenient and even possible sometimes, and they obstruct mental health care.
I would say that this is perhaps not to the same extent, because I think there's a great amount of stigma within mental health. But I think in terms of chronic disorders as well too, that that health insurance companies have a similar approach or kind of affect towards those individuals.
Well, particularly when they're serious. So, you know, certain diseases like asthma can be very mild, and then you're welcome at private insurance. But if you're one of those severe asthmatics who's in the emergency room 3 nights a week and in the hospital twice a month with asthma, and I hope you're not, then they don't want you anymore. So, you know, there's a range of illness, from mild mental illness or physical illness, in which case you're welcome in private insurance, or severe illness, in which case you're the opposite of welcome. And you know, how did we get a system set up like that? That's our finance system, is it's run by people whose financial interest is to make sure you do not get medical care. You know, people at some point will look back at the U.S. healthcare system and say, how did you ever do that? Why did you ever do that? And in fact, people in Canada do that. They look at the U.S. and say, you know, you may have better weather than us, but, you know, you have a terrible healthcare system. Why on earth would you do that? So, you know, my answer to that would be, there's these powerful corporations making a lot of money off of it, and they have a lot more influence in Washington, D.C. than we do. But by building a political movement, we can change that around and hold politicians' feet to the fire to get us a decent healthcare system that puts the health of the population ahead of profits.
Right, definitely. Even when it comes to mental health parity, some examples where mental health treatment is not in equal support as physical is where a lot of times people will be denied for care because they deem it as medically unnecessary, or not being able to find someone who is in network who is looking for new patients. So I definitely concur. And when it comes to the transition, you know, even in the past when psychiatric facilities or institutions started to close, there weren't any things to take care of that. So there weren't any community supports for those individuals. So they were left out unsupported. And I'm always bringing the personal, because the personal is political. And for me, when I was in a psychiatric ward when I was in college, after leaving that institution, I did not get any support afterwards. So to be able to leave a place and not get that care, obviously that's going to lead to worse health outcomes.
And especially in diverse populations, right, that have been systematically like isolated from their own people, or don't have that, because there are different aspects of support, right? There's financial support, there's social support, and they all have differential effects upon health and well-being, right? But they're all necessary in different ways. And so we really need to be able to culturally tailor our treatments as well too, and availability as well. I oftentimes in terms of, you know, we have to be able to provide a diagnosis and able to provide services for my patients that I see who have a brain disorder, right? And so it's really interesting that the guidelines that we have for diagnoses, they're really racially biased. And so a lot of times I find myself in a situation, because ethnocultural diverse individuals have higher comorbidity rates, where I'm not able to be provide a diagnosis to this individual just because they have XYZ background. And so it's not quote unquote high probability. And so these are systems, both in terms of science, clinical practices, and so forth, are really, really biased, even before we get to health coverage too. So it's something that there's a lot of work to be done moving forward.
Yeah. Even when it comes to mental health care for African Americans, they're more likely to be severely diagnosed when it comes to mental illness. So they're more likely, because of bias, they're more likely to be diagnosed with schizophrenia and other related disorders. Even the way the biases come across when Black women talk about the pain that they're experiencing and how they're ignored, and how so many Black women are not getting that support, not being heard. So it's just ridiculous.
So in terms of, were there any other, I think we're starting to get close to our QA time, but I think one of the comments that we did want to talk about, was there any other inequities that we wanted to speak to at this time?
I mean, specifically when it comes to infant and maternal mortality rates, Black women experience it 3 times more than white women. It's like 42.8 per 100,000. Like that's a huge inequity that is important to discuss as well.
Yeah, I know for me, you know, broadly, when we're speaking of queer people of color, so individuals who have intersectional identities, both in terms of ethnocultural identity as well as sexual and gender, you know, 1 out of every 2 of those individuals will have HIV. They'll acquire HIV throughout their lifespan. And so for that to be true here in America is astounding and outright unjust. And it's one of the inequities that we just don't speak about, right? Because who's it among? It's among this invisible group, right? The group that we don't really want to talk about, right? And so one of the things that we need to do as people is that we need to be aware of the inequities that are going on, especially among minority populations who have a smaller voice, a smaller prevalence, right? And what we need to do is we need to uplift those. We need to bring those up and be like, hey, this is an equity that we need to go on, that can no longer go on. We need to do X, Y, and Z. Right? The larger the inequity, the more work that needs to be put on. And that's why it's really important to understand historical and systematic oppression, right? And how that impacts health. What are these social determinants of health, and how can we alter and fix them? So I think at this moment, I guess let's discuss, I think that leaves us at a great place. So moving forward, we discussed in terms of course, healthcare. What are other ways that we can address inequities in health moving forward?
Well, we definitely need to end discrimination and segregation in housing, because many of the factors that Dior was talking about as social determinants of health are kind of captured in the neighborhood that you live in, whether the neighborhood has clean air, whether the housing is overcrowded, whether it's safe, whether you have walkable neighborhoods, public safety, so people can be out on the street, decent schools. So we need to uplift the minority communities. We also need to really outlaw discrimination and segregation in housing, which is rampant in the United States. You know, it's year 2020, and we think this should be a thing of the past, but study after study keeps showing discrimination of minorities in housing. So big priority there is to actually enforce the fair housing laws.
What about you, Dior?
Yeah, I think that it's important that we work with stakeholders, work with those who live in the community, who are from the community, making sure that they have a seat at the table. A lot of times people will say that when it comes to like seat at their table, that there is, you know, white institutions, white individuals, but really it's just like having a seat at the table, making sure that the healthcare professionals who are serving these populations reflect and look like those populations. So making sure that we're culturally compassionate when it comes to our care.
And I think that I would like to parse that out a little bit more and more granularly, and that when we speak of that, when we're saying, hey, people like me, people that I'm working with that are providing for me in any type of way, they should look like me. And what we're saying there is that, you know, representation is really important. And the reason why we're having these biases is because people of diverse backgrounds aren't at the table, right? And it doesn't necessarily mean that in every single interaction that you should be having, you only should be working with an individual who identifies just like you, right? That's not what we're saying here. What we're saying here is that we need diverse representation at every single level, right? So that we have a very fruitful and strong dynamic, collaborative dynamic between individuals. And that's true between scientists, that's true between clinicians, that's true between patients, right? And so forth.
Yeah, it's a blanket statement because and when it comes to seeing a mental health professional who is of the same race or ethnicity as you, that doesn't guarantee that you're going to be able to connect with that person in that same way.
Yeah.
We're complex individuals and we're not all the same. So when I see someone who isn't trauma informed or who doesn't have a better understanding of the LGBTQIA plus community. So definitely don't want to, as much as what you said, it's not something that's a blanket statement.
Yeah, no, definitely. And it's taking an individualized and culturally competent approach at every level, right? And that's why it's so important. If you're working on a team that does not have a diversity and inclusion team, you're not doing the right work. In terms of, really quickly before we sign off, I think we've answered a lot of our questions. I want to get to one point. What are some resources that we can provide to the people today in which they can tap into different ways that they can advocate for better health policies?
Okay, well, there are groups in many American cities that are still working around Medicare for All in New York City. There's the Metro chapter of Physicians for a National Health Program. It's part of a national organization I founded several decades ago called Physicians for a National Health Program. We have about 23,000 physician members nationally and several thousand, I think, in the state of New York. And we try to work with the nurses unions and community organizations to advocate for Medicare for All, but also more generally for issues of health and social justice. Certainly the DSA, I'm not a member, but it's a very good organization. Democratic Socialists of America has been working around health and Medicare for All. Our Revolution, which is the remainder of the Sanders campaign, I guess, grew out of the Sanders campaign. It's separate, I guess, organizationally, but very similar politically. So I would certainly encourage people to find organizations in the community. If you're interested in health, there's a lot of them around New York and around New York State that you could be working with.
Yeah, even when it comes to protesting, that's something that can be very powerful. But I also wanted to be cognizant of the fact that protesting is not something that all people can do. So knowing that you still have power in doing phone banks, writing to your local representatives, doing other things that can help the community, educating yourself, educating others. I think the more we know, the more we can advocate for ourselves. So definitely that's something that we should be doing.
Yeah, I think I'm going to pull out like my psychologist card really quickly. I think it's really, it's those moments in which you're able to touch someone who you normally wouldn't think that you would be able to connect with, or educate them in a manner in which, you know, you think is perhaps too distant from them and their experiences. Those are really magical moments. Not in any way should you feel an onus to have to do that to an individual. Girl, please, no. But, you know, we do want to kind of also emphasize that, you know, there is power in interpersonal connections, right? And there is healing in those moments as well, especially within and across communities. And the more that we can unify together and bring a unified voice, right? So really building empathy and sharing experiences with other individuals of diverse backgrounds, the better America that we'll be living in. Did I cut you off at all, Dior? Are you good?
Oh, no, I was just going to agree and say that allyship is not a noun, but a verb. And it's something that we should be actively doing to support each other. So,
yeah. So, and then I think now we have time for our QAs. We're at 7 o'clock. So we're gonna take, if Steffi and Dior are okay, take a little bit of time to answer these specific questions. Do you guys have a little bit more time?
Yeah. Okay,
great. So we have a question here that says, and I think Steffi, I think you did touch upon this. So it says, how does the patient system affect healthcare costs in the US versus other countries? And how would Medicare for All help with this? And I'm thinking of the graph that you depicted of in comparison of Canada and the United States earlier. Is that kind of, that, okay.
Yeah. Okay, well, Canada does have Medicare for All. If you get sick, you don't have, and want to go to the doctor or hospital, you do not take a penny out of your pocket. You just go, okay, because there's no co-payments and no deductibles. I mean, that's only a couple hundred miles from where I'm sitting right now, so this is not some sort of pie in the sky thing. And yet Canada's healthcare costs are about half what they are in the United States. Most of that relates to the much lower administrative costs if you run your healthcare system as a public service and not as a business where you sell commodities and try to make profits. You lower those administrative costs. We estimate that something like 17% of all health spending in the United States is just money wasted on excessive administrative costs associated with billing. And we published that several times. I think I showed some of the times we looked at that. Canada also saves money by doing better health planning, by making sure resources are there where they're needed and not duplicated in places where it's going to be redundant and raise costs. And they've emphasized primary care. So more than half of all their doctors are primary care doctors. You know, you can just get a primary care doctor, go without paying any money, and that doctor helps figure out how you're going to meet your needs and, you know, can help keep you healthier. So, so Canada, which is, you know, really a lot like the United States in most ways, you know.
Yeah, I was curious. So it's a really good comparison model, is kind of what you're saying?
Yes, it is. And, you know, there's other good systems out there. Scotland has a very good system, but, you know, probably most people on the call have been to Canada. I don't know how many of you have been to Scotland, but you know, it does really, these are countries that are culturally pretty similar to us and somehow figured out how to get everybody covered and spend half as much and have healthier populations than we do. So it's not impossible. The people who are telling you it's impossible are the insurance industry that is immensely profitable, the pharmaceutical industry that is charging you twice as much here for the same drugs as you can get, you know, half price in Canada, and a for-profit delivery, you know, parts of the delivery system are for-profit, not all of it, but some hospitals and nursing homes are for-profit. So those people are blocking change. They're leaving us with this extremely expensive healthcare system that is simply not delivering the healthcare or the health that the American people deserve.
I think a lot of individuals don't understand the large role of the pharmaceutical and the patent industry here in the United States in causing change for health equity. It is not beneficial for them, you know what I mean? And I know that with medicines for neurodegenerative diseases, when we look at the clinical trials for these diseases, it doesn't include any diverse populations at all. And so it's really all of our medicines are being targeted and trained for white, rich, upper class individuals, and typically males.
Yeah. But I mean, the pharmaceutical industry, when I first started doing research on health policy, I used to, the pharmaceutical industry used to sometimes commission studies to oppose my work scientifically. I'm pretty careful, so I didn't find any major mistakes in them, but, you know, they had like groups of researchers coming through the research that I did. And I used to sort of scratch my head and go, well, I don't get it. You know, I understand the insurance industry doesn't want me talking about Medicare for All, but why doesn't pharma? You know, why are they so opposed to it that they're hiring people to shadow my research and see if I made mistakes? Well, it turns out that other countries with Medicare for All or some form of national health insurance the government goes and negotiates with for-profit pharmaceutical companies. They have tough negotiations where the government says, if you want to sell your product in Scotland or in France, you're going to have to come down on your price, or we're going to get a product from another company. And because the national health programs in the other country does tough negotiating with pharma has to accept a price 40 or 50% lower than what it's charging the US for the same drugs. So I didn't even know this when I started out with this. Pharma knew it. They knew that Medicare for All or some other form of national health program was going to give a government entity the power to negotiate prices and push their prices down. So they are immensely wealthy, you know, that when they charge you $100,000 for one course of treatment for hepatitis C, they make a lot of profits. They have a lot of wealth. So they're immensely wealthy, and they wield that wealth to try to block change, not just to keep their pharmaceutical prices high, but to prevent any form of unified national health program that might negotiate with them for lower prices. So they're really a big part of the problem. Insure's #1 problem, because there's really no role for private insurance in an efficient, well-run Medicare for All system. But pharmaceutical is another really big problem, even though we're going to still need drugs with the national health program. They've really stepped in to try to prevent change in the system.
Yeah, and I see it's you know, America obviously has a huge overprescription issue, right? And one of the reasons why is because behavioral health is poorly underfunded, even though it's extremely efficacious, right? And usually in terms of best outcomes, it depends that you have both pharmaceutical as well as behavioral health working together to achieve like optimal health outcomes. And it's just not available. And us as psychologists, it's so sad we're not able to provide, you know, specifically diverse populations the care that they deserve. And so our next question speaks to, and I think Dior, this is probably more aimed in yours earlier. I don't know the exact context in which this question was stated, so we might need to brainstorm a bit. But it says, yes, I'm curious about the role of these various services in the context of interpersonal violence. So I'm not super sure of what that was speaking to. But in terms of maybe disparity in services provided for victims of abuse, or survivors of abuse.
Yeah, I would need more context, but specifically, like, because of COVID, because of isolation, domestic violence, you know, is more apparent because people are in these spaces where they have to be in the same space with their abuser. So there are resources, organizations where women can get that support, but honestly, in my personal experience, a lot of times, even orders of protection don't even provide that support. They just seem very useless. But I think I'm kind of speaking in general. But yeah, I guess I would need more context.
I mean, we can provide kind of our own diving board, I guess, into the conversation. I know that one of the things that's been a huge issue as well with interpersonal violence is also, you know, just within the Black trans community as well, and broadly trans women of color, more specifically, but also trans men and non-binary individuals and so forth, that, you know, the societal atmosphere that we're working in, you know, is really it induces violence and victimization and targeted attacks upon these populations. And it's just really disheartening. But I'm not sure, that's outside of my area of expertise, so I can't really speak to it so much. But yeah. Yeah.
Well, I mean, I've worked a little on domestic violence in the clinical context, in the sense of when a patient comes in, trying to work with people to help them resolve a domestic violence situation. One thing we need to make sure of is that everyone has access to help. That's the first step, and help that's not non-judgmental, that people who are willing to listen, willing to work with folks experiencing domestic violence to resolve the situation. And protection orders can be very important, you know, when violence can't be dealt with other ways, but we really need to strengthen people who are currently being victimized or trying to survive domestic violence and give them the tools they need.
Yeah.
So again, we just need to make sure that the medical services are available, the mental health services, the social work services are all available to people. You know, obviously we need a much less violent society. And, you know, when people are turning on the TV every night and seeing all this violence, and the police are meting out tremendous violence against minority communities, you know, toward gay communities, to bisexual and transsexual people in particular, you know, it's you're going to end up with much more violence coming home as well.
Yeah,
so
it's our system that we've built, right, that is attacking, right, and really in a violent manner, and it's not appropriate. I think one of the things that, you know, this is definitely an area in which policy for hate crimes and things like that could definitely be implemented and be forced upon. And, you know, when we're speaking of reforming police and things like that, these disparities and really murder and hate crimes are kind of an evident way of like, wow, this really needs to be done. It needs to be done now across different identities. I think that's kind of wrapping us up because we're already 12 minutes over. But thank you both so much. This was amazing. Do you guys have any closing notes that you'd like to leave with anyone?
No, it just, if people want more information, they might want to look at the websites of Physicians for a National Health Program. You could just use a search engine and find it. And there's the local chapters, New York Metro, but the national office also has website. And there's tons of information, like probably a lot of the studies that provide the background for the information that I presented. There would be copies of those studies up there on the Physicians for a National Health Program website. So I'm sure there's lots of community resources as well, but that's really the information resource I'd recommend on this topic.
Okay, thank you. Dior?
Just thank you for having us, for creating a space where we can have these conversations. Yeah, I just think that we all have the opportunity to make a difference, and it could come across in various ways. So there's not one right way to go about this.
Well, thank you all.
Everyone, stay safe, okay?
Thank you, the three of you, so much for this conversation. I learned a lot, and I'm sure a lot of the crowd did too. Yeah, so thank you again for all joining tonight, and hopefully we'll see you next week for our policy panel on immigration.